Hello, lovely friend. I am Dr. Mary Barson.
And I'm Dr. Lucy Burns.
We are doctors
and weight management and metabolic health experts.
And this is the Real Health and Weight Loss Podcast. Hello, lovely friend, and welcome to this episode of the Real Health and Weight Loss Podcast. I am Dr. Mary Barson, and today I am very excited to be joined by special guest Dr. Louise Phillips, who is a GP extraordinaire. Dr. Louise Phillips is an Australian general practitioner in Queensland. She works at the Albany Hills Radius Medical Centre. She's got over 20 years experience and a strong passion for metabolic health and medical education, as well as supporting doctors to thrive. She's lead educator and content director at Low-Carb Scripts, where she helps clinicians confidently use nutrition, especially low-carb approaches, to improve the health of their patients and their patient outcomes. Alongside her clinical work, Dr. Louise teaches medical students at the University of Queensland. She mentors GP registrars, which are GPs early on in their career, and she contributes to the Australasian Metabolic Health Society, helping shape the future of metabolic health in Australia. Known for her practical and down-to-earth approach, Louise is passionate about making complex science simple and understandable. And she's also passionate about helping both patients and doctors create that sustainable and meaningful change. So, Dr. Louise, it's so good to have you back. Last time you were on the podcast, it was 2023. So it's been a while. So tell us, I'd love to hear, what do you think has, changed since we've last had you, and what do you think is happening on the ground right now, with everyday Australians?
Yes, so I think an enormous amount has changed since I last spoke to you. One of the biggest things I think is the US dietary guidelines having changed and basically becoming a low-carb food pyramid. I think that really gives us all hope in Australia that our guidelines will change. And I think it gives confidence to patients as well that what we previously were prescribing very differently from the food pyramid, it is now sort of modern and up to date. So I think that makes things a lot easier. And I also think the fact that very low carbohydrate diets are recognised as being one of the 3 ways of reversing type 2 diabetes, and Diabetes Australia lists it on their website as, in their management section as being appropriate to use. And all of those things enable practitioners to practice with a lot more confidence that they're not going against guidelines. And there's so much more, I think patients are so much more aware of it. There's so much more availability of low-carb options nowadays, especially low-carb beers. I think the fact that there's so many low-carb beers out there shows how much it's being adopted mainstream. Yeah.
Absolutely. I myself am quite a fan of low-carb beer. When I go camping, I'm grateful. Yeah. It's just so freely available right now.
Same.
It doesn't require a special trip into Geelong. I can get it at my local rural town.
No.
Yeah.
Absolutely. Yeah. That's
yes. Right. For completion, one little thing you said there I thought was really interesting, that Diabetes Australia recognises it as one of the 3 ways to treat and reverse type 2 diabetes. What are the other 2 that they mention?
Well, bariatric surgery, and then the third one is very low energy diets, so shakes and things like that, which do work in the short term but are generally unsustainable in the long term due to people being hungry and regaining weight if they go onto a normal sort of diet.
Yes. Well, I think my bias is probably, fairly obvious to everyone, but I do believe that a well-balanced low carbohydrate approach is a great way to improve your metabolic health and manage type 2 diabetes. So your genius zone, I think one of your genius zones would be fair to say, is your ability to communicate and to help other people communicate too. This is like the whole basis of low carb scripts, is that it helps busy doctors be able to communicate this really important and really helpful information in a simple and easy way. So I would just love to know, when you're sitting down with a patient, say a patient who is struggling with their weight or their blood sugar, or could have pre-diabetes or type 2 diabetes, how do you explain insulin resistance in a way that actually clicks for them?
Sure. So And I'll also just say that I'm a mainstream GP. So I'm a family doctor. So I see everyone from babies through to elderly people, and they could come in with absolutely anything. And often their metabolic health is not really the first thing that they're coming in for, and it's not at the forefront of their mind, although it's the thing that's going to help them the most in the long term. So keeping that in mind, I think in general practice as well, I work in 15-minute timeframes, and if I have long consultations, they're half-hour timeframes, and so that has to be taken into account as well. So in general, if someone is coming in and say, for example, has fatty liver, that's a pretty easy explanation. If they don't drink alcohol, then it's caused from fructose, which is the sugar in fruit and sugar that's added to anything. And I would recommend that you cut those things down. So that doesn't take very long to explain. And I do have a handout about fatty liver. In general, though, what I'm explaining to people is along Jason Fung's analogy of the sugar bowl, which is that sugars come into the body in the form of fruit, sugar, and starch. And once your bowl is full, it starts to overflow, and we're seeing either the blood sugar going up, or we're seeing that sugar turned into fat in the liver, fat around the middle, or fat in the blood, which is what high triglycerides are. So that's sort of the simple terms. And so we've got to stop the sugars coming in. And I take very much I actually don't prescribe keto diets per se very often, unless someone's specifically coming for that. I prescribe low-carb real food, similar to what you guys do probably, but any improvement towards real food and towards lower carb is going to be beneficial to your health. And then I've got a one-page handout which explains to patients how to eat a food label, and it's got 10 tips on it. So I will go through with them the important things with reading a label, which I believe are read the ingredient list first. If it's got more than 5 ingredients, it's an ultra-processed food. You should be able to understand everything on that ingredient list. And then I get them to look at the carb total per 100 grams. And we're aiming for 5 grams per 100 grams and avoiding sugars and vegetable oils. And then the other things I tell them, it sort of depends on what they've come in with. I often give that handout, and I'll often run through a few things that are on that handout, like eat real food, eat no more than 3 times a day, eat the protein first, eat more protein, those sorts of things. And so it's actually quite easy. And it does surprise me how often someone whom I have thought when I saw them, oh, I don't really think this person's going to engage with this, or I've sort of just got the feeling that maybe they didn't quite buy in, that they might come back and see me 6 months later and they've lost 5 kilos and they're feeling great, and all I've given them is one piece of paper and a bit of advice.
Yes, that's beautiful. You're leveraging that therapeutic relationship you have with them. It is interesting to say that it's often not what they come in with, but you're still able to weave it in and still get them to a point where they can leave with something that is going to be helpful for their metabolic health, which we know long-term is going to be one of the most important things for their long-term health and health span.
Yeah, and because people often come in, because you would know this having a general practice background as well, that they come in and they're tired, not just from diet, but from burnout or mental health or other things going on as well, or perimenopause, which is a massive thing at the moment. So if they're not iron deficient and their thyroid's normal, but their liver's out or their bloods are fatty, you can sort of leverage into that. Like, I think it's due to your metabolism's not working properly, and we can look at diet. And people are quite open to a diet-first approach, I find, in my clinic anyway. And I'll say that I do work in a Brisbane suburb. It's middle-class demographic. So that every GP in Australia will have a different demographic. And I think that's the value of GPs, is that you get to know your patients over a long period of time. You know what their family structures are like. You know what other pressures might be there. And so it enables you to give helpful advice that's a little bit more realistic, I think, than even, say, a dietitian who's met them once, you know, or so much more about them.
That's right. You walk the journey with them, and you can, filter the advice through the context of their life, which is one of the truly beautiful things. Yeah, that longitudinal care with general practice is something that I really love about it. It would be fair to say, I think, that the healthcare system in Australia comes under quite a lot of criticism, and I think that general practice comes under quite a lot of criticism. And there are these real constraints that that we must work with in general practice. Things like time pressure, 15-minute appointments is something that we need to find a way to work with. And I just love that you are not only finding a way to work with it for yourself, but also helping other clinicians as well.
Yeah, for sure. Look, I think that prescribing lifestyle medicine is extremely rewarding. I'm much happier in my career helping people because you actually see people's health improve, but it takes time. It does take time, and you can chunk it up and you can do it over short segments of time. And I often do also get people to come back for a half hour and then I go through with it in depth. But you can't expect, I don't think, a general practice population which is overworked, quite burnt out, I'll say, dealing with a tsunami of chronic disease and then expect them to fix it in 15 minutes when people also have their own financial and time pressures and they don't want to necessarily come back to see the doctor about some things that they don't think are that important. So that's why with low-carb scripts, that's why I specifically have got a very inexpensive 1-hour course called Running on Time for $30 to teach GPs how to run on time. And then there's, another short course about managing your life at home so that you're less burnt out. Because I think unless you help doctors become less burnt out and to be able to run on time, they're not going to be motivated to prescribe lifestyle advice when prescribing a pill is so much faster.
Yes, that hits home like a punch in the stomach. I love that. Yeah, no, it really does. I certainly got quite burnt out when I was a GP registrar, like a rural GP registrar, and I ran late all the time and I didn't have a great understanding about creating good boundaries. I didn't have a good understanding about protecting myself. I had fabulous mentors, these lovely rural GPs, but they just didn't have the same problems as I did. They were male, which was part of it, but also they were just different to me. They attracted a totally different patient cohort. And I had sort of collected a very large cohort of patients with a very challenging constellation of symptoms, mental health, drug addiction, all these sorts of things. And yeah, I didn't know how to keep myself well.
Yes. And unless you're taught, because most doctors are naturally empathetic and caring, that's why we went into this job instead of becoming, some other sort of field. It's because we care about people who want to help them. But come with that, you do have to learn to set boundaries. And that's definitely something that I talk about. And I've had another job where I've sat in with 60 to 70 GP registrars and as a external teacher, observing their consulting skills. And almost all of them will want to know how to run on time. And then you get a few who want to know how to prevent burning out. And for me, I can completely appreciate that. But it's sad because these doctors are very junior in their career, and if they haven't been taught these things, you're sort of alone in the room by yourself. No one's really giving you feedback usually unless you get one of these visits. It's really sad to see people who have been trained for so long, for so many years, have worked so hard to get where they are, to end up in a position where they just can't manage the system. Because it's not just the patients, it's the public system, it's the private system, it's the costs, it's the drug industry, it's pharma, and it's also the food industry. Like it's all of that together, plus their own life, which might be falling apart. Yeah.
Absolutely. Absolutely. We're inside this GP world that in Australia, look, our healthcare system could be a lot worse. It really is pretty good on the scale of things. From a patient perspective, how do you think patients could better have conversations with their GPs about their concerns, about particularly concerns about their metabolic health? What could patients do, this is our beautiful listeners, do to help make that whole process work better for them?
Sure. In terms of helping the doctor a little bit, and I know doctors don't run on time all the time, but if a patient turns up late, particularly at the start of the session, say if they turn up 10 minutes late, the next 10 patients are waiting an extra 10 minutes. So you've added 100 minutes of wait time to the wait room straight away. So turning up on time is very helpful, and also booking an appropriate amount of time. If you've come in with 6 or 7 things and you've booked a 15-minute appointment, that's unrealistic to cover all of that safely. So understanding that it's best to get the list up out front. I had a patient on Friday and their last thing on their list, which I had gotten out up front, was chest pain in 15 minutes. And it's like, okay, well, we're going to be dealing with this today because the rest of it, we can't do that safely today as well as chest pain. So I think getting the list up out front, but understanding that just because you've come with a list of things, it doesn't mean that all of those things can be dealt with at that appointment, that appointment may be a triage appointment where what you really want done gets done, or what's really important, like chest pain, gets done, and making a plan for the rest to be done, to understand that it's going to take time. If something has been affecting you for 10 years, it's probably not going to be fixed in a 15-minute conversation.
Yes. As I'm listening to you, I have an appointment with my GP in 2 weeks' time that, I made 3 weeks ago, and a list does form. I am aware of how general practice works being a GP, but I do see myself doing that. The list is coming in my head as this appointment accumulates, and I do know most of it's to do with perimenopause issues. That's what the list that I'm accumulating right now, and we all do that. What do you mean by, just for the people who are listening, to get the list out at front? I know what you mean, but explain to our beautiful listeners what you mean by that.
Sure. I'll give an example of a patient. So a patient will come in, so I've come in for a few things today. I'll tell you the easy one first. Okay. And that might be a script. Okay. So that's okay. But I really want to know what are the other 4 or 5 things on your list, because you've probably put the most important thing you've come in about at the end. And if I get the list out first and I say, well, we've got 15 minutes today, I can send you for a blood test for these things and get you to come back for a half-hour appointment, patients will accept that early on. But if you get the list out one thing at a time over the 15 minutes and you get to the most important thing at the end and you say, look, I don't have time to deal with that, you'll have to come back. Patients hate that. They do not accept that very well at all. And so that's why your job as the GP, or what I would suggest is the most important thing if you want to run on time, is to get the list out and then limit it at the start. And you're not limiting it to be mean. You're limiting it because you're realistic with what you can do in that amount of time. And most GPs are pretty expert at, this, as they go through the list, okay, that's going to take me 3 minutes, or that'll take 5 minutes. Or, it's so finely tuned, your time management and general practice. It's hard to believe if you're not a GP. My daughter, she's a medical student, and she had her first session where she sat in with a GP recently, and she's like, Mum, I had no idea what you do. Like, people come in with so much. I don't understand, because they have exams where they've got to do part of it, like take the history in 8 minutes or so. They're like, how do you do all that in 15 minutes? Because you're taking the history, you're examining, you're diagnosing, you're managing, and you're walking them in and out and typing your notes at the same time. So it's tricky. Yeah. It
is. I saw one of my colleagues had a coffee mug which said, not just a GP, I'm a multitasking time ninja. And I thought that was very great. And I really wanted that mug.
You could make a whole stream of those mugs, I think. Some could be multitasking time ninjas. Some could be multitasking, not doing so well.
Yeah,
GPs could opt in for whatever stage they think they're at. Yeah.
That's right. And it will vary from day to day, I'm sure.
Yeah, and it's impossible to run on time all the time. I'll definitely say that things happen.
Oh, they do.
All the time, unexpectedly. So, yeah.
Yeah, absolutely. And indeed, that in rural practice, that's one of the things I find most uniquely stressful is when the emergencies come and, there's the only doctors in the whole town are there. So, often we have to stop what we're doing to deal with a chest pain or something like that. And then the whole day blows out, and that is a unique cause of stress. So bringing it back to our beautiful people listening. So most of the people listening to this are patients, definitely doctors do, absolutely. When you're dealing with the people in your general practice, what would be your approach, to someone who's perhaps feeling completely overwhelmed by their health? Where is a place that you might start? And, what sort of small changes do you think can really help move the needle for people?
Sure. I think probably there's 2 things that I think are the most important things to consider. One is, if the patient is depressed or has so much stuff going on in their personal life, I think unless you get the mental health aspect a bit more settled, it's very hard for them to do the lifestyle changes. And I'll even say that to them. And the second thing is, I think a lot of people don't take a dietary history. It's really fast. It takes 2 minutes to ask people what they eat and drink in a day. And oftentimes you can just find that one simple thing, like, do you think you can switch to low-carb bread? Or can you stop the banana? Could you have a mandarin instead? Things like that. Can you not snack after dinner? There's some little changes that you could suggest, and then they can go away. And I'll usually say something along the lines like, "Is that possible? Do you think that's doable for you?" And a lot of the time they're like, "Yeah, I could try that. That's great." And then you follow them up the next week. So you're just getting them to tiptoe in and building on successes, but they may need help with depression or seeing a psychologist or so. And a lot of people, I think, do comfort eat or have food addiction, and that's something that needs specifically addressing. And so in my practice anyway, we work with a psychiatrist called Dr Angelo Giovannis, and he has a specific technique called mind behavior therapy. And essentially it's taking action on anxiety at an earlier stage. So as soon as you notice that your mind is racing or your heart is beating faster, whatever it is that's your anxiety symptom, then we get them to try to pull back at that point. And they can pull back using a sense, mindful breathing or warm herbal tea or whatever it is. Sometimes we use medication as well just to pull back, because as you guys have said before, I'm sure I heard it on your podcast, when people comfort eat, it's not usually the worst part of the day. Like, you go home and eat a bucket of ice cream, that's not the most stressful part of your day. It's been because you've pushed through the whole day, and then you've lost all your reserves and you're exhausted by the end of the day. So we use this technique. That's the main technique I use with patients. And as well as GPs, I mean, we can treat anxiety and depression and things like that as well. I suppose it's the analogy with comfort eating is just trying to prescribe some other additional tools that they can use to manage their anxiety. And it's a little bit like if you're trying to build a house, you need hammer and nails, you need drills, wood, etc. If you only had cake to build that house, like, it's not going to work so well. And so if people's only tool for dealing with their emotion is cake, it's not going to work very well in the long term.
I love that. And that's really taking it away from shame and blame, isn't it? The cake is a tool.
Oh, yeah, totally. Oh.
And it's not necessarily right or wrong.
No. And, in medicine, we talk about PRN medications or as-needed medications. And these are medications that you need sometimes. So for someone with allergy, for instance, they might take an antihistamine as they need it if they got hives. That would be one thing. So people are using comfort food as their PRN, their medication, to try to make themselves feel a little bit better. And so we're replacing it with a different PRN, a different as-needed medication or tool.
I think that is beautiful. A lot of people, I find, can often feel quite stuck. Perhaps also that, like, it's too late as well. I don't know if you see that with people that kind of feel like it's too late for them to change.
Yeah.
Yes. So I'd love to know how do you help patients see through that? How do you help patients who are feeling stuck or feeling like nothing's going to help?
I guess a lot of people haven't tried this before is one thing, but if you keep doing what you're doing, you'll probably keep getting the results of what you're getting, and it's really about your trajectory. So if you already have got insulin resistance and high blood pressure, etc., and you're 40, then your life when you're 70 or 80 will be bucket loads of pills, loads of admissions to hospital, that sort of thing. Whereas if you can do things, and that's the important thing about low carbohydrate diets, is that they can reverse disease. They can make you feel better. Not reverse all disease. I think sometimes people are a bit unrealistic as to what you can reverse, but people can feel better. And so you may not fix everything, but you alter your trajectory. And that's what's important. You can always change something. Someone feels bad about how they look, and they get their hair cut, they're going to feel loads better. So, if you just stop alcohol, or you start a different thing, because people get hope from little things, I think, and just getting some movement makes them feel so much better.
It definitely starts to build that self-efficacy and that self-belief that they can change. Yeah. You said before that lifestyle medicine is much more enjoyable for a doctor than other forms. Could you illustrate that for us a little bit more, perhaps even give some de-identified examples of what you mean by that?
Sure. Okay. So I love medicine. You see the mother through her pregnancy, the newborn comes in for their checkup, and that's always lovely to see, and you vaccinate them. So these are healthy people, right? And then otherwise in general practice, you might see someone and they're on 8 or 9 different medications. They're feeling depressed. They got pain in their knees, all of that sort of stuff. They're spending $130 at the pharmacy each month, probably, and they come in. And so if you can just help them a little bit and their blood pressure improves, or their sleep apnea improves, or they've lost weight, the first thing you would see would be their energy improve, their brain fog lifts, their mood improves. They visibly look lighter in their face, their eyes are brighter. They're grateful. And it's often said that, I talk about in some of my talks online that I hope this isn't offensive to patients at all, but for GPs, the golden trifecta would be a patient that was diagnosable, fixable, and grateful, right? Yeah. And you get that with low-carb medicine, because a lot of what you do in chronic disease, you can't fix it. Here's a pill, just continue on. Or in medicine, in general practice, there's so many shades of grey. It could be this, or it could be that. Oh, in a year's time, it might be obvious what this is, but at this stage, it could be 20 different things. And sometimes people don't appreciate that. Whereas in low-carb medicine, the blood results are I personally think, are so indicative of metabolic health. They're so reliably reversible if they're following the diet. And if they're not reversing, that doctor needs to think again about the diagnosis. There might be, something else happening, and it's not just all metabolic health. So that's sort of what I mean. I guess it's easy to diagnose, it's easy to fix, and patients are really grateful. Yeah.
Yes, I do. I love that. For our listeners, could you tell us a bit more about the blood tests? So the blood tests are really indicative. What do you test for and what do you look at?
Sure. So I will say that it's quite hard to order certain tests because of the way Medicare funds blood tests. So you can't order vitamin D unless the patient pays $50. But the test that I order is I'll order a full blood count to check for anemia. I'll check a liver and kidney panel. I'll check thyroid function, just a TSH. I'll check their iron levels. And then I will check a HOMA-IR, which is a measure of insulin resistance. So it's a fasting insulin and a fasting glucose. And then if the patient's eligible or they're willing to pay the $20, I'll order a HbA1c, which is a measure of how sugary their blood's been in the last 3 months. And that's pretty much all I order for most people. Sometimes if they're vegetarian or something, I might order some other vegan or something. I might throw in a couple of other tests. So I keep it pretty simple like that. And from the lipid profile, if their triglycerides are elevated above 1, if their HDLs, well, for women, it should be above 1.3. For men, it's above 1. There's certain cutoffs that I look for and certain cutoffs. And then if a patient has any of those, I'll flag them and I'll do a recall to invite them back for an appointment, say in about a week's time, depending on how urgent it is. If it's very bad, I'll call them back earlier. And then go through it with them.
Yes. And do you find that, is it a good thing to track as people then make changes and their metabolic health improves? Is the blood test, you find that helpful?
Definitely. I love Dr. David Unwin's approach. He's a big metabolic GP in the UK. And for patients who have, when they have big improvements in their blood sugar control, their HbA1c really comes down, he prints it for them and he gives them a gold star or equivalent of, congratulations, well done. And sometimes I'll do that with patients. I won't put a gold star on it because I don't have those. But I think effectively, it's very encouraging that you've been working so hard. The blood metrics usually do improve. They don't all improve at once, I find. I find blood fats are the slowest to improve. However, they do improve. It's encouraging for patients. And equally, if they're deviating, GPs need to really take notice of what Dr. Unwin would call an uptick. If the blood sugar is starting to go up, pull that patient in, ask them about it, try to encourage them back again, because if you miss that uptick, it will tend to just go on and on sometimes, not always, but sometimes.
Yes. I love that we take a moment to celebrate those wins. Celebrating wins is so important for behaviour change. Yeah.
Absolutely, because it's, as you know, like, it's not just about weight and waste. It's how they feel, it's their pain, it's all of those things that are really important to as you say, celebrate. Yeah.
Fantastic. So could you tell us a bit more about low carb scripts and what it is that you do there?
Sure, absolutely. Thank you. So Low Carb Scripts is a teaching platform, and it's designed to help health professionals, be they GPs or, if you're a nurse or any allied health person as well who's interested in low carb and would like to learn more, to teach you about it in the most practical and succinct way possible. So I learned about low carb through a very expensive, very long course that was harder than medical school and GP training put together. And I don't think it needs to be that hard. It's actually quite simple. So my courses are based on science and research and stuff like that, but also based on a lot of case studies so that I show people how to interpret blood results, how to interpret calcium scores, those sorts of things that you need to be able to do, because doctors need to be able to detect it. So you need to pick it up on the bloods and you need to implement it, and you need to help people with food addiction and all those sorts of things as well. So that's the education part. And then it's also providing resources as well. So there's the Low Carb Doctor's Kit, this is what I use probably 6 times a day with my job. It's a visual images that I've created that you just click through on your computer and explain a very simple spiel with patients. You give them some handouts, they can ask questions. And so that's the doctor's kit. And then there's also, because if you do low carb medicine, you end up seeing patients, perhaps because you're on a website or something, who are a bit trickier. They might be a bit more knowledgeable on low carb or not low carb. And so you need to sort of know about some other things, or, there's stuff about vegetarian diets and things like that in an information pack that's a separate pack of 51 handouts. And then there's Running on Time, which is my most popular course, teaching GPs how to run on time. And then there's Tools for Wellness, which is time management at home and also reducing burnout at work, like strategies that you can use at work to minimize your stress dealing with complex situations and complex patients as well. So that's my offerings.
Oh, that is a fantastic collection of offerings, both for GPs, but also for the people that they're seeing. And where can people find you if they want to learn more about what you do? Where can we find you on the interwebs?
So my website is www.lowcarbscripts.com. And then I'm a GP at the Albany Hills Radius Medical Centre at Albany Creek. So people can book in the usual ways, which is online or by phoning the receptionist, and all new patients get a half-hour appointment.
Fantastic. And we'll put those links in the show notes too. Today we've been talking a lot about behaviour change. And at the moment, Dr. Lucy and I have got a special deal running with our hypnosis program, our 31-day hypnosis program, which can be a powerful tool for lasting behaviour change. Check it out. If you're interested, head on over to rlmedicine.com/feel-better. Link will be in the show notes. And we have a special deal running throughout the month of May. If you use the code HYPNO, you get $50 off. So do check that out. Dr. Louise Phillips, thank you so much for coming on the podcast. I've really enjoyed this chat, and I'm a big fan of the work that you do. And it's been wonderful chatting to you, and I hope that we can have you back again for a third time.
I'd love to. It's wonderful talking to you, and this is fun talking to you as well. So thank you for that. Thanks for having me back.
Thank you so much. Okay. Bye, everybody.
The information shared on the Real Health and Weight Loss podcast, including show notes and links, provides general information only. It is not a substitute, nor is it intended to provide individualized medical advice, diagnosis, or treatment, nor can it be construed as such. Please consult your doctor for any medical concerns.